Morning, everyone, and welcome to the second annual Rolling Starts Traumatic Brain Injury webinar. We are honored to have you join us today as we come together to raise awareness, share knowledge, and support individuals and families impacted by traumatic brain injury. At Rolling Start, we believe in empowering our community through education, advocacy, and connection. Today's webinar is an opportunity to learn from professionals, hear valuable insight, and strengthen our commitment to improving the lives of those living with TBIs. Thank you to our presenters, community partners, and each of you for taking the time to be a part of this important conversation. We hope today's event is informative, encouraging, and inspiring. Welcome, and thank you for being here with us today. Now, with that said, let us get started. A Center for Independent Living. Next slide, please. What is independent living? What is independent living? A cultural movement and a program, a way of looking at disability. Centers for Independent Living works towards equal opportunity for people with disabilities to share in all benefits of society. We serve people with any disability. That means cross disabilities, whether it's visual, hearing, or whatever disability it is, we serve. And we serve people from 0 to whatever age that is that they may leave this earth. Independent living centers are designed and operated by a majority of people with disabilities. That means that 51% of our people who work for a Center for Independent Living has a disability, and 51% of our board members have a disability. Next slide, please. The IL network. There's 28 centers for independent living in California. Rolling Start is one of the 28 centers for independent living. The Department of Rehabilitation is one of our major funders, and Administration for Community Living, ACL. All you have to do to get our services here is to self-identify yourself as a person with a disability. Rolling Star's funders, we fund the San Bernardino area, Mono counties, Inyo counties, some of Riverside, and some of San Diego, just depending on the funders. Next slide, please. Our core services are information and referral, independent living skills, system change and self-advocacy, peer advising and groups, transition and diversions. We have some additional services. Next slide. That is assistive technology and voice option. Voice option is one of those programs that we service people with TBIs or someone who had a stroke and can't communicate through their own voice. We use a technology device to help them to communicate. We also have disaster preparedness program. We also are partners with the Aging and Disability Resource Connection, San Bernardino County, ADRC. We are core partners. And of course, we have the Traumatic Brain Injury Program, which I'll talk a little bit more about. We have employment and vocational support services. And we have the Veterans Direct Care services. Next slide. Rolling Start was awarded a grant to service people with traumatic brain injuries. We've always serviced traumatic brain injuries, but we didn't have funding for it. So in 2024, we were funded a 3-year grant to be able to support people with traumatic brain injuries in various ways. Increase our outreach and communication, improve access to services, Supportive living. Supportive living could be the help with education. It could be the help with a computer. It could be whatever type of support that would help that individual to be able to live an independent life. We also help with consumers and caregivers navigation systems, helping them to get the services that they need. We have a employment specialist who help our people with TBIs to either get a job, get prepared for a job, or help write resumes and so forth. We also have public and professional education helps, data and assessments. For more help with our traumatic brain injury, you would have a referral sent to our own TBI specialist, Mr. Richard Starks. And that's the email address that you would reach him at. Next slide, please. And that's here we have our main office in San Bernardino on Hunts Lane, and then we have a satellite office in Victorville on Victor Street. You can follow us on social media at the various social media sites. Okay, at this time, we're going to introduce Dr. Charlie Dawson, MD. Dr. Charlie Dawson is a brain injury fellow at the University of Kentucky, where he is dedicated to helping patients rebuild their lives after a neurological injury. He cares for individuals across the continuum, from acute inpatient rehabilitation to outpatient recovery, treating conditions such as traumatic brain injuries, stroke, cerebral palsy, and other acquired brain injuries. Driven by a deep commitment to patient-centered care, Dr. Dawson focused on managing the complex complications that follow these conditions, with a mission to restore independence, dignity, and the highest possible quality of life for every patient he serves. He believes that recovery is not just about physical healing, but about empowering individuals to reclaim their lives and identities. Originally from Nebraska, Dr. Dawson began his journey in medicine at Midland University before earning his medical degree from Meharry Medical College. He went on to complete his residency in physical medicine and rehabilitation at Nebraska Medicine, where he developed a strong foundation in rehabilitative care. He is currently completing his brain injury fellowship at the University of Kentucky, with plans to finish in June. Great. Dr. Dawson is passionate about advancing the field of rehabilitation medicine and is committed to making a lasting impact on the lives of patients and their families. Welcome, Dr. Charlie Dawson.
Hi, my name is Dr. Dawson. So I just wanted to thank you for the introduction. So before I get started, I just wanted to give a little background on how this actually came to be. So I actually met Jennifer, who will be on a little bit later at a brain injury conference in Philadelphia. And Jennifer had asked some really good questions about how some of the things that they were talking about, some of the presenters, and how it would affect patients with brain injuries over the long period of time. And really, there wasn't much information. That conference was mostly based on what we could do at the initial injury and not what would happen over time. People who were giving the talks weren't really talking about how brain injuries affect people over long periods of time, 3 months, 6 months, a year, and even further on. And that's where Jennifer and I kind of had this conversation, and we started to have a conversation or talk a little bit more. And so this led me to this presentation that is about some of the things that I see with patients with traumatic brain injuries, and what my role is, and what do I do to help people get as independent as possible moving forward after their traumatic brain injury. So that's kind of the name of my presentation. So. So first, I was gonna give a little bit of background about what kind of doctor that I am. So, I am a physiatrist, and so what does that mean? That means I am a doctor of physical medicine and rehab. The number one question I get is, "Am I a physical therapist?" I am not a physical therapist. I do not do any therapies. I'm not gonna make you squat 100 times or anything like that. But I will say that I work very close in hand with physical therapists. Um, so something that's also interesting about PM&R is that we and our in general, our goal is to restore function, kind of like what we were talking about a little bit earlier, reduce pain and improve quality of life in patients after their disability, whatever that may be. We don't have a specific organ that we would say, hey, this is we own this organ. Kind of like cardiologists say, hey, we take care of the heart. Nephrologists say, hey, we take care of the kidneys. We kind of work all together with that. We work very closely, like I mentioned, with physical therapists, occupational therapists, speech therapists, and nursing as well. And then a little bit more about where we work. So, physiatrists in general can work in very many different settings, but I would say that the most time we spend our time is in inpatient rehabilitation. So, after a patient has their traumatic brain injury or stroke or whatever they may be, and they're not quite ready to go home yet, they need some intense therapy. I call it boot camp before they're ready to go home. They go to a place to where they get 3, 4 hours of therapy a day to kind of work on those deficits, and then make them as independent as they can. And then also, many physiatrists also work outpatient, so taking care of some of the complications that come from different conditions that we treat over time. Just some general physiatrists that what we take care of is joint back pain, all kinds of sports injuries, stroke care, brain injuries, what we're all here for. We also take care of patients with amputations and spinal cord injuries as well. And so I wanted to give a little bit more background about me specifically. So, brain injury physiatrist, that's what I am. So it's a subspecialty of PM&R. So what I went to did all my training doing general physiatry, and then I wanted to spend more time taking care of patients with brain injuries, whether it's both from traumatic or non-traumatic injuries. So things that I take care of that are non-traumatic or like stroke, cerebral palsy, hydrocephalus, and anoxic brain injuries, and then traumatic brain injuries. And I'll get a little bit more into that here as we go on. And some things that I specifically take care of with patients with traumatic brain injuries is cognitive impairments, post-traumatic headaches, mood changes, spasticity, and like I said, I'll go into a little bit depth in some more of these things, but equipment needs, helping to develop a personalized rehab plan. And that's kind of where I said I work very close in hand with the therapist. I help with issues with bowel and bladder and pain from brain injuries. So to get a little bit more about traumatic brain injuries and how do we classify them and to what degree. So um, in general, there's three classifications of traumatic brain injury. So it's mild, or we use it interchangeably with concussions. There's moderate, and there's severe. And how we base what level that you fall into is based on three things, right? It's your Glasgow Coma Scale, your post traumatic amnesia, or your inability to make new memories after a brain injury, and your length of loss of consciousness, right? So the worse your GCS is, the longer your PTA is, or your inability to form new memories, or the longer your length of consciousness is, though that kind of puts you more into a moderate to severe. And for this case, I'm gonna focus more on the moderate to severe. with mild TBIs or concussions. This is by far the most common. Probably everybody knows somebody who's had a mild concussion or a mild TBI or concussion at some point. But they typically get better, overwhelmingly get better. There's a subspecialty or a little bit, a few patients who have prolonged symptoms, but for the most part, everybody they heal on their own. And so I spend most of my time taking care of moderate to severe. Another form of traumatic brain injury is blast injuries. So if you think of like a tank exploding or something like that, and not directly getting hit with an object, but like the force of the blast can cause a traumatic brain injury. And then I also take care of, and there's penetrating traumatic brain injuries. So unfortunately, gunshot wounds, stabbings, and gunshot wounds are typically the most common penetrating brain injury. And my experience, most of the time, it is self-inflicted, unfortunately. So I decided to dive into a little bit more of some of the things that I see, and I spend and that limit patients the most and make it harder for patients to get back to how they were before their brain injury. And so the first thing I want to talk about, and I spent the most time on, is the cognitive impairments, um, and just some. And so I'll give some examples of things as I kind of talk through. But so the most common cognitive impairment after a traumatic brain injury is the slower processing speed. It's patients that can understand what you're saying, and they can follow the commands. It just takes them a little bit longer to do that, and it can be very difficult for patients and families because a lot of times there's like an awkward silence, and it's not that they don't understand, or if the patients don't understand, they can't follow through. They just need an extra minute. And a lot of times patients or people are like, they must have not heard what I said, I or they're not understanding. So they repeat it before they give the patient enough time to respond. Another very common complication is attention and concentration difficulties. So before, sometimes patients will say, "Hey, I could do whatever I need to do for hours and focus, and I could concentrate and I could have no issues." Well, after a brain injury, because of the part of the brain that's affected, mostly the frontal lobe, um, it's hard to focus. It's hard to concentrate for long periods of time. And then difficulty with executive function. So especially this is more common early on in a brain injury, where patients are impulsive, where maybe they can't walk quite yet, but they get up and go to the bathroom. They think they can get up and go to the bathroom, or they think that they can. They may have some issues with swallowing, but they're not aware, or they don't think they have the deficits, and so they just do that, and it's not safe for them to do that. That typically gets better over time, but it can be very challenging to treat in the beginning. And then I kind of touched a little bit on that, is patients not being able to like recognize their own limitations. So not realizing that they have a cognitive impairment, feeling like they are exactly the same person that they were before their brain injury, feeling like there's nothing wrong with them, feeling like they can go home and drive and go back to work right away, almost immediately after their injury. And so, one of the things that, obviously this can play a huge role in effective returning to work, and getting back to the quality of life, and doing what you're doing before. So there's this thing that I like to call cognitive fatigue, and I don't know if there's a direct diagnosis to this, but this is what patients usually tell me, that, man, if I can only do something for 5, 10 minutes, and then I just can't do it anymore. Where previously they were able to do things for hours at an end without having that issues. And sometimes it causes their symptoms to worsen the more they do, especially headaches and vision changes. So that can be really, obviously, could be very difficult to return back to work, given that. The same thing with multitasking and focusing. So it's very hard. It can be very hard for patients to switch from one topic to another. Through all of our work days, there are times when we have to set something down and go do something and come back. It can be very hard for patients with traumatic brain injuries to set something down, go do something else, and come back to it, and can increase their cognitive fatigue. Um, Difficulty with learning new tasks and adapting to changes, kind of like the same thing I mentioned. As we grow in our job and as we change, things are bound to change, and um, it can be very difficult for patients with traumatic brain injuries to do those changes and adapt. It takes a little bit longer. They can usually, but it just takes a little bit time. And then because of the brain injury itself, in the part of the brain, the frontal lobe that is affected, it can cause issues with relationships with your coworkers and supervisors, not being able to find common ground, being afraid to or limited in their ability to communicate effectively. That can, being working, you need to communicate with somebody, no matter if it's who it is, and so that can be very hard for patients with traumatic brain injuries. And this is one of the most difficult things that I deal with, and it's really hard for not only the person with the injury, but the family as well. Like I said, I'll keep mentioning it because of the damage to the frontal lobe that controls our emotion, our impulsivity, or higher level thinking. Um, Patients with traumatic brain injuries can be irritable and have emotional changes, and it could be very difficult to treat. I put this in a quote because I've heard this a few times from different patients and their families, and it's unfortunate, but it's this person is not the person I married anymore because the frontal lobe really controls our personality, and so personalities can shift dramatically after a traumatic brain injury. A lot of patients will tell me, "Hey, I know that I don't need to be this upset about something so simple." They're quicker to anger, and so the minor like annoyances turn into things that they can't move on from. So, like last week, I was talking to a patient, and somebody cut him off, and while he was driving, and that would annoy anybody, but he just couldn't get over it. Talked about it all day, frustrated, took it out on his family and kids, and that's just their inability to process their emotions, and it can be very difficult to treat. Um, and because they have the lack of ability to patients sometimes have the lack of ability to like concentration and focus that we talked about. It could be interpreted by as they don't care, as patients don't care. Um, Sometimes patients will say, "Hey, I hear you, but it's kind of like I'm daydreaming. Like I can hear the words, but they're not kind of registering for me." You have impaired empathy and social awareness too. Um, you, because of your inability to process and um, about what's going on and maybe following social commands. You could patients and on top of that with their impulsivity, they can say things that just come straight to their mind without kind of thinking like, hey, you know what, maybe I should hold off on saying this. This is not the right time. And over time, that can cause issues with family dynamics, friendships, even romantic relationships. And then this can also lead to depression and anxiety, which can further limit recovery from a traumatic brain injury. And I'll discuss a little bit about that moving forward as well. So what do I do about it? How do I get patients to get back to being themselves? So a lot of times it's medications, right? So it depends on what their deficit is. Is it issues with memory, focus, concentration? It just kind of depends because the medications that I use target um, depend on the impairment that they have. And then, as I'll talk about a little bit, there are a lot of medications that patients are given in the beginning of their recovery that can affect their cognition as well. So it's important to try to wean some of those medications off as they heal. I also mentioned earlier that I work with speech therapists. Speech therapists are amazing. If anybody's here, speech therapists, thank you for what you do. I just tell patients in general, therapists work with speech therapists, how we think, how we speak, and how we eat. Um, and a lot of patients will say, hey, my speech is fine, but they'll work on cognition, memory, focus. and it's very important. And then as patients recover from their brain injury and they start to heal, we want to get a neurocognitive test, right? So what this does, it tests different domains of cognition, memory, focus, concentration. It helps us decide if maybe there's anxiety or depression that's overlying as well. And it basically tells us what their deficits are, and that helps us address them better. So whether it's through a more specific therapy plan, medications, or whatever it may be, and then moving forward, this can give us data on helping patients get back to work and developing accommodations that they might need. And so another thing that PM&R or physical medicine or rehab treats that maybe not a lot of other folks do in the medical field is called spasticity. And one of my favorite things to treat is the technical term is velocity dependent increase in muscle stretch. And that's kind of a lot of words there, but basically what it means is that when somebody's trying to move your arm, it's like resisting somebody. It's just like something's resisting. Some people, patients or families will describe it as like tight muscles. And what you'll see is maybe you'll have abnormal posturing. So maybe you've seen a patient who's kind of like this, or their hand is in kind of like that tucked in. That's a spasticity. And so, how does it affect patients' outcomes, right? First of all, and it can be painful. Just imagine your muscles being tight and contracted all day, every day. It can cause pain. Depending on where the spasticity and how affected it is or how it's treating the patients, it can interfere with their walking. So sometimes patients can't put their heel down all the way on the ground. And so it's hard to walk on your tippy toes, or sometimes their foot turns in a little bit. So they're walking on the side of their foot, and that can make it very difficult to walk. And then what's the goal is a lot of times is to help with ADL. So if a patient is kind of like this, it can be hard to clean in the elbow. It can hard to be cleaning the fingers. And then if we don't clean that, they're an increased risk of wounds and breakdown. And honestly, caregiver it's can increase caregiver burning as well. And then if we don't treat this can lead to contractures and joint deformities. And at that point, we're talking about surgical intervention and trying to hold off on that. So how do we treat it, or what do I recommend? So stretching, and stretching. Those are my three first line treatments for spasticity. Whether it's done in formal therapies or encouraging patients and the caregivers to stretch daily. A lot of times patients are and their families like, hey, what can we do? What can I do to help them? And that's what I tell them. There's not enough stretching that can be done, as long as the patient can tolerate it from a pain perspective. Sometimes we work with different, whether it's OT or PT, on bracings that kind of help prevent the contractures from developing. We use medications such as they're muscle relaxers. I just put some names out there, so maybe if you guys come across that, you'll kind of understand what we use them for. And what's really tough, and what we spend a lot of time talking about, is these can affect your cognition. And as we remember, we talked a lot about cognition being very impaired, or could limit patients the most moving forward through a traumatic brain injury. And then a lot of times the main side effect is sleepiness. And so trying to find that balance between treating the spasticity and the cognitive impairment is what I spend a lot of the time when I do it, or a lot of my time doing. So neurotoxin injections, Botox is the big one. If I had $1 for every time somebody asked me if I could put Botox in their forehead for wrinkles or something like that, I would be rich. I'd be on the beach somewhere, wouldn't have to work another day in my life. There's Botox, Xeomin, Dysport. They're all essentially the same. They just they're just brand names. Like there's different type of like tissues. Kleenex is just a brand name, and so this is what I do a lot. And this is for best for treating focal spasticity. So maybe one arm or a few muscles are affected, and that's or they can't tolerate the medications. And then surgical interventions. We could talk about after long periods of time is a baclofen pump. And what a baclofen pump is a little bit of it's like a little circular device that kind of goes in patient's abdomen, and it puts baclofen directly onto the spine itself. So it's kind of dripping the relaxing medication on the spine. It's really good for patients with lower extremity spasticity that can't be treated with other means. And then tendon releases kind of as well as going in there and cutting that tendon that's tight. I'll have to back up a little bit. When it comes to neurotoxin injections itself, so based on, we can decide what muscles are affected by the positioning, and then we decide, okay, if the patient has this or this position, we should target this muscle with this many units with the goal to do this. That's kind of how I approach treating spasticity. Another big thing that I take care of, and it all kind of goes back to the cognitive impairments after traumatic brain injury. And so it's insomnia after traumatic brain injury, and this is very common, especially early on in the recovery, but it can go on chronically. So um, it could be injury to the parts of the brain that regulate the sleep cycle itself, right? It could also be, there's a bunch of neurochemistry changes that happen that I won't bore you with, but that can affect the way that we affect our ability to sleep. And so another thing that can happen is patients after traumatic brain injuries could be anxious given what's happened to them. Depression, that's, their life is going to look different now. And PTSD, as they relive those events, all those can affect your ability to sleep. You also have things like spasticity that we talked about can be painful. Headaches can prevent people from sleeping, and pain from other traumas sustained. So usually a brain injury itself is not the only thing that happens with a patient. So a lot of times they have broken bones, or they have and they suffer some internal damage. And so treating that as well can help them sleep better. Why do I care so much after insomnia after TBI? Because if you don't sleep, it can affect your recovery significantly. So, after traumatic brain injury, it can impair your attention, your memory, your focus, and executive function. All those things that we need to do to function on a higher level on day to day, and also can lead to mood and mental health complications. Whenever you don't sleep well at night, me as well. We're kind of rude, irritable the next day, maybe quicker to anger. And I don't have a traumatic brain injury, so um, it can lead to depression and anxiety as well, which can kind of affect the recovery from a brain injury. And this is a big one. So you when you don't sleep, it reduces the ability for the brain to like learn and restore. This is what we call, maybe you heard of it, neuroplasticity. And I tell my patients, rest and restore. And so, usually early on in their stay, I tend to be a little bit more aggressive with medication management to get them to sleep, because it can really affect outcomes. It gets our sleep can be so involved in patients' recoveries that sometimes we can kind of tell how they didn't sleep last night very well, just based on how they're doing in therapies today. Um, and then if you don't sleep, very tired during the day, can affect your work or school performance, how well you're doing in therapy, which is big for us while we're in acute inpatient rehab. Also can impair your social functioning. So, like I said, quicker to anger, maybe not as empathetic. And then overall, untreated insomnia leads to lower quality of life and greater disability for the reasons I just mentioned. So what do we do about it? Or what do I do about it as a brain injury physiatrist? So first is non-pharmacological. So we want to make sure that we're going to bed at the same time every night, trying to wake up at the same time every day. Limiting naps, and that can be very very difficult in the beginning, as patients they need to sleep to get back to their function. But we want to kind of limit those naps, because once patients get their nights and days confused or delirious, it can be very difficult to treat. So limiting screen time before we go to bed, so limiting iPads and phones, and then making sure we're staying active during the day. That's easier during inpatient. where they're getting 3 hours a day, but a little bit more difficult once you get home. And then a lot of times patients have underlying obstructive sleep apnea. And so making sure we get that treated as well. And then, like I said earlier, one of the main things that I work on is medication management. So melatonin is always the first line, but a lot of patients say one, it doesn't work, or two, it gives them nightmares. And then so we'll kind of escalate that necessarily. Um, I'm all for trying to use one medication for multiple reasons. So patients don't have to have, 3 or 4 medications. So addressing the underlying cause of insomnia is important. So we kind of talked about, is it pain? Is it anxiety? Is it PTSD? And they can kind of help us target what medication we may or may not use. Another thing we talked about in the beginning a little bit was what do I help patients with is what kind of equipment do they need to be successful at home or wherever they may be. And so what the goal is for that is to help the patients or their families maintain their independence and safety. Again, I work very much with interdisciplinary, so PT, OT, speech, and different vendors. One of the most common things that I talk about as patients is, when is it time to go to a wheelchair versus a walker or a cane? Um, MWC stands for manual wheelchair, so one that they can push versus a power wheelchair, one that they have to drive. And one of my favorite things to work with is like augmentative and alternate communication devices. So maybe if you've seen somebody communicates with the iPad, or sometimes where they can kind of push the button, or sometimes they can track their eyes as well to kind of help communicate. This is great for patients who they can't um, they can't communicate, but or they can't speak very well, or they're not able to, but they can still communicate somehow. And this can be really change a patient's outlook, and help them maintain their independence, because essentially they can tell you exactly what they want and communicate just like it would be with anybody else. I kind of talked about this a little bit, but bracing for spasticity to prevent contractures for development. And then for foot drop, sometimes when patients walk after their brain injury, if this is how your foot should normally be, their foot kind of drags, right? So they kind of drag it when they're walking, and it's at a huge risk for falls. And we don't want patients to fall because they increase the risk of brain injury. So there's a device that we use called the ankle foot orthotic that kind of, the goal is to bring the foot like this. So patients can have a normal gait, as normal as it can be, to decrease their fall risk. Like I said, these things can very much decrease the caregiver burden as well as help the patient be independent. Another thing that can be very troublesome and very difficult to treat is substance abuse, even before and after a brain injury. So, around 50% of people are intoxicated when they sustain their injury. So that's a huge, as a pretty much everybody, I would say, when it comes to inpatient rehab, a lot of them come with alcohol involved, whether they were the ones that were driving or drunk and driving, or having alcohol involved, or the person that caused the injury was drunk as well. And then because of some of the things we mentioned, issues with the mood and lack of able to like communicate, some patients turn around 30% of patients turn to alcohol after their injury. And I spend so much time. This is important to talk about because um, abuse, specifically alcohol, that's what I'm spending most of the time on, is can really affect patients' outcomes over long periods of time. So um, it can increase the extent of the brain injury or the brain damage itself. So the brain atrophies over time. So you're just getting less brain mass, which is harder to do what you were doing without the brain mass that you had previously. It can exacerbate the existing neurological sequelae. So all those things that we talked about, alcohol makes it worse. Lowers the seizure threshold. So a lot of patients after a brain injury, they're at increased risk of seizures, and whether it's short term, long term, and when patients are drinking alcohol, that can lower that seizure threshold. and a lot of times they're on medications for seizures. And when patients are drinking alcohol, it can affect that medication as well, making it not as efficacious. And then kind of what we talked about before is the increased risk of psychiatric impairments and suicide. And that's, I would say, that's probably the biggest concern that I have or that I see in my clinic. And then there's an increased risk of additional traumatic brain injuries, whether it's from falls, whether it's from driving intoxicated, whether it's from getting into altercations. Usually, when alcohol is involved, there's an increased risk of traumatic brain injury. What do we do about it? So a lot of times it's cognitive behavioral therapy, working around the things around why are they drinking? How can we effectively change their thought process around drinking? Alcoholic Anonymous is a great tool here to kind of get mentorship and maybe talk to patients and other folks who struggle with some of the things that they're going through. And then pharmacological, that's a little bit more difficult. There are some things or some medications that are used for patients with traumatic or for patients who don't have traumatic brain injuries to help with their alcohol cravings. But a lot of times the data is not great whether or not we use it in patients in traumatic brain injuries. Other complications that we take care of, and I spent a little bit less time talking about this than others because I just wanted to make everybody aware. So, vision impairments. So, as you can imagine, it has implications in returning to driving, working, and even increases the fall risk. Post traumatic epilepsy. Um, Discussed that a little bit more about the seizures previously, but in most, it's a little bit different, but per state. But usually, it's around 3 to 6 months where you can drive if you had a seizure. So like you have to have like 90 days minimum. A lot of places having seizure free before you can return to driving. And then long term medication requirements. So um, and a lot of those anti-seizure medicines have a lot of side effects. So um, continue to monitor the side effects as well as those. Um, Hydrocephalus, so that is basically buildup of cerebral spinal fluid in the brain. And so when we have our brain, there's parts of our brain that makes this fluid that kind of protects our brain and our spinal cord. And when you have a traumatic brain injury, that fluid, the outflow, or even the ability to get the fluid back to your brain is impaired. And essentially it can cause like expansion of the brain. And so it can limit patients' ability to progress further. So a lot of times I see this is when patients aren't progressing as far as I expect them to, or as quickly as I would expect them to, um, based on my experience and based on how they were doing previously. Sometimes a therapist will say, they'll come and say, "Hey, Dr. Dawson, the patient just seems more tired, more confused, not participating in therapies anymore like they were." That kind of puts me on attention that patients maybe is having hydrocephalus. And then another thing I take care of is neurogenic bowel and bladder. After a brain injury or a stroke or any insult to the central nervous system, there's a lack of communication between the brain and the bowel and bladder. And so sometimes patients they can feel when they have to go. Sometimes they can't. Sometimes they can completely empty. Sometimes they can. It kind of just depends. And so this can lead to skin irritation and breakdown, leading to wounds, recurrent urinary tract infections, renal failure, and patients don't want to go out into the community and return if they're afraid that they're going to soil themselves out in public. So that's also a big one. I want to spend a little bit of time of prognosis, a little bit. So Short answer is there's no clear way to predict meaningful recoveries after a traumatic brain injury. I've seen patients who I thought would never make it. I thought maybe they would pass away in the hospital. And then 6 months, 7 months later, they're back to driving, they're back to working. And so it's very heterogeneous, as some patients do really well and some patients don't. But I would say that most patients with moderate to severe traumatic brain injuries improve. And I can't tell you to what extent. But when they come to me in acute rehab, usually the first day that I see them is the worst that they tend to be, unless something comes up that may affect their participation, or like if they're having worsening spasticity or issues with sleep, or headaches, things like that. And so it's hard for me to tell or families and the patients like, hey, this is what you're going to look like in 6 months, to a year. Really difficult to say. And so, and it's all kind of what the families think as meaningful. Between me, you, whoever, what is fine as meaningful could be very different. Um, and patients usually get better. The maximum recovery is like the first 3 to 6 months, and that's when we see the like significant improvement over the first 3 to 6 months, right? And then after the 6 months, patients still improve, but it tends to plateau around a year. That doesn't mean that patients can't get better, but the goal is to maximize what they have, whether it's like in therapies, is kind of what I'm saying there. Some things that we do know is that if you're less than 40, and um, um, from an adult perspective, you tend to do better, right? Those younger than 4 tend to do worse at their traumatic brain injury, but I'm focusing on adults here. And I kind of talked about this earlier. The length of post-traumatic amnesia, or your inability to make new memories, the longer that is, that's associated with worse outcomes. And then the injuries to the brainstem, which kind of control a lot of our functions that we don't think about, like breathing and blinking. When patients have injury to those, worse outcomes. One of the things that I wanted to spend a little bit more time talking about, I know some folks who've recently had or been taking care of a patient with some patients with traumatic brain injuries, and I reached out to a lot of people to kind of talk to them, and to get a little bit more information about how does a TBI affect the family members or the caregivers. So, in my experience, patients with very involved caregivers and family members do better in recovery from the traumatic brain injury. More support, more encouragement, things like that. They're more likely to go home after they do inpatient rehab to get back home. Um, and then patients, this is a big thing, and I spend a lot of time with, unfortunately, is that patients who don't have good support system or caregivers, it's hard for them to get to their appointments. So we can't address the things that need to be addressed to make them as functional as possible. Like those things that I talked about earlier. Patients who have very involved families, they always make it to the doctor's appointment, the therapist, whatever, to maximize their recovery. However, from the caregiver aspect, this is very, 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 very challenging. So and affect their physical health, right? So sometimes older men, they fall, they have a brain bleed, they hit their head, and their only caregiver that they have is their wife, who's half their size, and so she can't physically pick him up, or she might try, and then she's at increased risk of hurting herself. That's a very common scenario that I see. Emotional distress, secondary to social isolation, um, increased financial strain, increased family strain. Patients, a lot of times, caregivers have to stop whatever they're doing and dedicate their full time taking care of the patient. Sometimes it can be, the goal is to have multiple family members, but sometimes that isn't an option. And paying for full time caregivers, a lot of times insurance doesn't cover that, and so a lot of times patients and families have to pay out of pocket, which can be extremely expensive for patients and their families. And a lot of times, I will maybe ask the patient's caregiver separately, like, "Hey, how are you doing?" And they'll tell me things like, "Hey, I haven't been to the doctor for since this happened. Like, I'm not sleeping. I'm anxious. I'm nervous." And obviously, I'm not their doctor, but encouraging them to take the care that they need. I understand it's easier said than done when you don't have a great support system besides that individual person. So, um, next slide. And so, what do I do about it? The first thing that I do, like I said, is, and I think anybody can do, is just ask the caregivers how are they doing. I think just acknowledging that this is tough for them is meaningful. I think it's powerful. And so I always try, like I said, to tell patients, hey, or their caregivers, hey, you're doing a good job, okay? I try to get patients and their caregivers involved in support groups. So here at the University of Kentucky, there's a support group. At the University of Nebraska Medicine, where I trained at, there was a support group. And it's not only for patients with brain injuries, it's for families as well, where patients can kind of come together and their families can kind of talk about their experiences and maybe what worked for them and what didn't work for them. There's also support groups online. A big one is the Brain Injury Association of America. Um, I try to help with them finding respite care. So, like I talked about, finding other family members to help, but this can be very, very difficult. Especially with our older patients who don't have anybody, or um, their children live on the other side of the country, and so that can be very difficult. Always talk about mental health, like I said. Referral to psychology, support groups, and also that educating patients and caregivers about their TBI symptoms and their recovery, what this typically looks like, or what we would do for it, but taking our time and try not to overload them as well. I like to get my patients and their family members involved in the decision making because it's a team approach. I don't live the day-to-day life that they live. I don't take care of the patient every day. So getting them involved, I think, is helpful. And I help patients all the time with getting disability and FMLA to try to help up with that financial strain that they're experiencing. So that was kind of my presentation. There's a lot of nuances into these things, but I just wanted to kind of give an overview of what I do as a brain injury physiatrist, and how these things go untreated or they go untreated or unaddressed, or they're not addressed significantly, can really impair patients' ability to take care of themselves and their outcomes moving forward.
Well, thank you. A whole lot of information, so much information, and we just thank you for giving us that information. I have a brother that have a traumatic brain injury, and so some of those things you were saying, I totally related to, because he
Mm,
totally is a different person today. So thank you for that.
mm.
There are some questions that um, first question is POTS dysomnia something that falls under they say yeah,
Yeah. Yeah, I
care.
got it. I got it. I got it. It's like a whole other
Okay.
language there.
Yeah.
Yeah. So dysautonomia is a dysregulation between the sympathetic nervous system after a brain injury. So typically, what happens after a brain injury is that you have the sympathetic nervous system. Maybe you heard of the fight or flight system, and
Mhm.
then there's the rest and digest system, right? So after a brain injury, that fight or flight response is elevated, and so what happens is sometimes something noxious is like bothering them. So like maybe they have an itch or a scratch, or their Foley catheter is clinked or something like that, and they can't communicate, and their brain doesn't have the ability to say, "Hey, it's all good, calm down. It's just this one little thing." And so the sympathetic system goes into we call it storming. So into a very significant response where they're hypertensive, or their blood pressure goes up. Their Sometimes their heart rate can go up. They can have fevers, and it could be very difficult to treat. Versus it can look like a seizure sometimes. And so and general physiatrists do help manage this, but that's more of a inpatient thing. So like right in the acute hospital that they're at. So yes, we do help manage that, and it can sometimes be very difficult to manage. And patients, they can't come to acute rehab when they're storming that much.
Okay. Next question. Have you worked with someone with trigeminal? No, I can't pronounce
Yeah,
this.
trigeminal neuralgia. Yes. So a lot of when patients hit their head and they have a brain injury, there's a millions of nerve endings and firings in your face and in your head that can be damaged, whether it's from the way that our brain interprets the pain or it's from the trauma itself. And so there's a bunch of nerves that kind of sit here. They kind of shoot on your face right here. And so after that, it can have like a shooting pain that can be very devastating. It can hard to brush your teeth, eat. And so, yes, there are some medications that we can do to manage that. So,
There- Next question. So this is the question. I deal with that in the ankle and foot, contractive, contracture and spasticity to tender cuttings and lengthening possibility.
yeah. So, my question would be to you: have we tried all of the Botox or any neurotoxin injections? If you tried that, I usually tell patients we have to give it 2 or 3 times because we might have to adjust the dosing or what muscles we target. If you tried that and you tried medicines and you tried therapies and nothing seems to make and giving you the relief that you want, then I would say yes, you might want to talk to an orthopedic surgeon about tendon lengthening to help recovery and help you maintain your independence.
Next question. Is it common to be forgetful?
Yes, extremely common. It is one of the most common things that I talk about. Whether it's short term, I think short term memory is the most impaired in patients. Um, and so, what do we do about that? We kind of talked about the medications, but working with therapists, they're like the speech therapists, they're great helping define ways to overcome your deficits. So maybe setting alarms on your phone, maybe writing things down, using an Alexa. They're really good at experiencing that. So
Next question. Is there another question? Is aphasia mainly due to TBI? What treatments are there?
yes, so aphasia is either an inability to understand or an ability to get words out. So it's either expressive talking or receptive, like you're not quite understanding it. It is commonly seen in patients with traumatic brain injuries. It's also seen in patients with strokes. And so the biggest thing, there are some medications that we use to help with aphasia, called donepezil, maybe memantine. But the mainstay treatment is speech therapy, working on those ways to communicate and working through the issues that you have.
Last question is, I have a friend with short memory loss. She had the memory loss for close to 15 years. Is there any hope for her?
Great question. The first thing I would want to make sure is that there's not some other underlying cause, like making sure she's sleeping well, making sure her pain is well tolerated, making sure she doesn't have medications that might be affecting her cognition. If she's and then the question would be maybe trial and medication to help with her short-term memory, and then to see if that's an improvement. And if none of that is helping, then I would unfortunately say, hey, after 15 years, what you have is most likely going to be what you have. And so the goal then would be to um, transition to maximizing what you have, as far as like making sure we're doing reminders on our phone, making sure we're going to therapy, things like that.
Well, thank you. Now we're going to turn it over to Jennifer Raby. Thank you so much.
Thank you, guys.
Okay, hi everybody. And first of all, thank you, Dr. Dawson. You did an amazing job. Wow, that was such good information. PMR. Awesome, awesome, awesome. Well, I am Jennifer Vilraby, and I am one of the program managers here at Rolling Start. Oh, good morning, and it is a pleasure. Okay, well, I have the exciting privilege and honor to introduce our next speaker. Are you ready? Are you sitting in your seats? Are you excited? Isn't this information just wonderful? Well, I'm here to introduce Peter Pettis. He is the neurofeedback. So, Peter is the founder of the California Neurofeedback, a Riverside based business dedicated to making neurofeedback technology. That's his picture. More neurofeedback technology more accessible and affordable for individuals seeking support for mental health and cognitive challenges. Through his work, he helps people explore alternative approaches to improving emotional balance, cognitive function, sleep, and overall well-being. Raised in out here in Southern California in the Inland Empire, he developed an early interest in health care through his family's connections to the medical field and his own experience navigating mental health treatment. After struggling with emotional imbalance and finding limited access and success with traditional approaches, he discovered neurofeedback technology in his early 30s. Wow. And it made a difference. And it has experienced significant improvement in his overall mental health and emotional well being. Inspired by the positive impact the neurofeedback had on his life, Peter founded. Dun, 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 dun. What did he find? Well, he founded California Neurofeedback to help others gain access to the same tools that help him regain a sense of calm and confidence. Wow, that's just such amazing. Since then, he has worked with individuals from all walks of life, including veterans, professionals, and traumatic brain injury survivors, helping them improve cognitive function and quality of life through neurofeedback training. I present to some and present to all Mr. Peter Pettis. Thank you.
Hi, Rolling Start, thank you for having me. And thank you to everyone here, survivors, families, advocates, staff. I'm glad to be in this room with you all, even if it's a virtual one. My name is Peter Pettis. I own California Neurofeedback. We rent neurooptimal neurofeedback systems to people who want to train from home. I'm going to explain what that means and why I think it matters. But first, I want to tell you why I'm really here. Not as a business pitch, not as an expert, but as someone who knows what it feels like when your brain is working against you and who found something that helped. And I want to introduce you also to someone whose story is far more powerful than my own. In my 30s, I began experiencing lingering anxiety and depression that felt like a heavy blanket draped over me, casting darkness over my life and stifling the light inside of me. A minor issue at work or with a family member could trigger overwhelming anxiety, ruining my entire day. Then the depression would kick in, spiraling me into despair and leaving me feeling worthless and out of control. Life became small. Things I once enjoyed felt like burdens. Going outside, having fun, even spending time with people I loved became a challenge. I felt hollow inside. And the thought running through my head was, maybe this is just who I am. I had already tried therapy and medication. The anxiety and depression persisted. Ugly thoughts about my worth and the point of my life became pervasive. I hated how I felt. Life sucked. Even in my darkest times, my family stood by me. They worried, they supported me, they remembered the happier and more confident version of me, even when I couldn't. My mom, in particular, refused to accept that this was my final form. She was the one who introduced me to the neurooptimal neurofeedback system. At first, I was skeptical. How could a computer system help my brain become more balanced and resilient when therapy and medication had failed? But after some research, I discovered that neurofeedback had been used worldwide for decades to support people with chronic emotional, sleep, and cognitive challenges. And I learned that Neuroptimal allowed me to train at home on my own schedule. Encouraged by that, I committed to a series of sessions. Research suggested that many people noticed improvement within 15 to 30 sessions, so I set out to give myself at least that chance. Over the course of 30 sessions, I felt a gradual but undeniable shift. It was like crawling out of a cave into the light. Stress at work and at home no longer consumed me. My anxiety loosened its grip, my depression began to fade, and joy crept back into my life. I can enjoy socializing, being outdoors, and most importantly, I felt like myself again. Next slide, please. That was more than 5 years ago, and the results have lasted. Because of what Neuroptimal did for me, I started California Neurofeedback. My mission was simple: to make this life-changing system accessible to anyone who wants to take charge of their mental well-being, rediscover their joy, and feel like the best version of themselves again. And when Rolling Start's TBI coordinator reached out to me about 2.5 years ago to ask whether neurofeedback could benefit TBI survivors, I didn't hesitate. Now I want to be straight with you about something. What I went through was real and it was hard, but I didn't have a traumatic brain injury. I'm not going to stand up here and suggest that those two things are the same, because they're not. TBI changes things at a different level entirely, things that most people never have to think about: the ability to concentrate, to sleep, to hold a thought from one end of a sentence to the other, to regulate your emotions in a moment of stress. Recovery isn't a straight line. Some days feel like ground gained, other days feel like ground lost, with no clear reason why, and underneath all of it, there's often this quiet, exhausting question: how do I get back to who I was? What I've come to believe after 2.5 years of working alongside Rolling Start's survivors is that the people in this community don't need to be rescued. They've already proven that they can survive things most people never get tested on. What they need is access. Access to tools, honest information, and the belief that the brain is still capable of more than today suggests. I want to tell you about someone who showed me exactly that. I've changed her name to protect her privacy. I'll call her Brittany because I didn't have the chance to ask her permission before sharing her story today. But her words are entirely her own. Brittany is one of Rolling Start's TBI consumers who trained with one of my Neuroptimal neurofeedback systems. Before she came to neurofeedback, she had been through a great deal: an aneurysm surgery, motor vehicle accidents, sports injuries, and years of physical and emotional pain that had built up over time. She came into her first session carrying all of that. She told me the wires and sensors caused her some anxiety at first because they reminded her of the electrodes from her surgery. That was a real response and a completely valid one, but she didn't quit. After a few sessions, it got easier. She found her own way getting into the sessions, watching landscape videos, reading Bible scriptures, and using her session time to meditate and remind herself how far she'd already come. Here's what Brittany said in her own words. After using the neurofeedback program, I have better focus. My sleep is good, and the anxiety symptoms are improving. If I feel the anxiety coming on, I can cope better. It's like my thoughts shift. I don't react to stress the same way. Before this program, I was struggling due to my physical health. It was weighing on me mentally. I was concerned that I would have to go on anxiety medication. I have suffered for years, stemming from traumatic events, sports injuries, motor vehicle accidents, and other painful life events, as well as having a medical diagnosis that could be life-threatening if left untreated. All this has caused me great physical, mental, and emotional pain, but I am getting better. I don't overthink things as much. I have returned to taking classes, and I hope to return to my former career and interests. I am hopeful and thankful. Brittany. She's taking classes again. She has goals. She's moving forward. That's what this is really all about. Not miracles, but a person who has been through tremendous hardship, finding a little more steadiness, a little more focus, and a little more of herself, and building on it. Now, let me explain neurooptimal neurofeedback, what it actually is and what it isn't, because most people have never heard of it, and the ones who have usually have a vague or incomplete picture. Neurooptimal gives your brain real-time information about its own activity. Your brain generates electrical signals constantly, billions of them, all the time, without you ever thinking about it. Neurooptimal's technology reads that activity and reflects it back to you almost instantly. Think of it like a mirror, but for your nervous system. When you look in a mirror, the mirror doesn't tell you what to do. It doesn't say, fix your posture, or you look tired. It just gives you accurate, real-time information, and your brain uses that to respond. You adjust. Not because someone pushed you, but because now you have something to work with. That's the idea behind Neurooptimal. Now, I want to make an important distinction here, because not all neurofeedback works the same way. Traditional neurofeedback is directive. A practitioner decides what brainwave pattern your brain should be producing, programs a target protocol, and the system then rewards or discourages specific brain activity to push your brain toward that target. It's a top-down approach, someone outside your brain deciding what it needs. Neurooptimal is different. It's what's called dynamical neurofeedback, and it's non-directive. It doesn't set a target. It doesn't tell your brain what to do or try to push it anywhere. Instead, it continuously reads your brain activity and reflects information back the moment it detects a sudden shift towards stability. Your brain receives that signal and responds on its own in its own way. No protocols, no preset targets, no one outside your nervous system deciding what's right for you. That distinction matters, especially in a room full of people whose whole mission is empowering others to achieve the independent life of their choice. And I want to be direct. I'm not here to tell you that neurooptimal neurofeedback is a treatment or a cure for a traumatic brain injury. It isn't. I won't make promises about what it will or won't do for any particular person because every brain is different. Every injury is different, and every recovery looks different. What Neurooptimal is a supportive brain training tool, one that's been used around the world for decades. The research around neurofeedback and TBI is still a growing field, and more studies are needed. But the findings so far have been encouraging in areas like attention, post-concussive symptoms, anxiety, and mood regulation. It's one tool. For some people, like Brittany, it becomes a meaningful part of the path forward. So what does a session actually look like? Next slide, please. It might surprise you because it's a lot simpler than most people expect. You sit, next slide, please. You sit somewhere comfortable, a couch, a recliner, wherever you feel at ease. Small sensors are placed on your scalp and ear clips go on your ears. And I want to be clear about this. Those sensors don't send anything into your brain. They don't stimulate. They don't zap. They just listen, picking up on the electrical activity your brain is already producing on its own. Then you put on headphones and you relax with music, a movie, a video, whatever makes you feel calm. Brittany chose landscape, videos, and Bible verses. Next slide, please. Other people use music they love or a show they enjoy. There is no right answer, whatever settles you in. While you relax, Neuroptimal is reading your brain activity 256 times per second. And when it detects that rapid shift, that sudden shift towards stability, the audio pauses for a fraction of a second. A tiny interruption, subtle. You might not even consciously notice it at first. That pause is the feedback. That's it. That small, repeated signal, many times over the course of a session, is giving your brain information. Your brain registers the interruption and responds on its own. You're not trying hard. You're not solving anything. You're just there, relaxed, while your brain does what it's designed to do, adapt. Sessions run about 33 minutes. Some people feel calmer or clearer-headed afterward. Some sleep more deeply that night. Others notice their thoughts feel a little more settled or that they're less reactive to things that usually get under their skin. And for most people, those shifts build and become more lasting as sessions accumulate over time. I'll acknowledge what Brittany mentioned because it's honest and it matters. The sensors and the ear clips can feel unfamiliar. For someone who had electrodes on her head during surgery, seeing wires attached to her scalp carried real weight. That response was valid. I talk about it openly with the people I work with. I don't brush it off. But she also told us what happened. After a few sessions, it got easier. She made it her own experience, and she kept showing up for herself. That's the shape commitment usually takes. Not zero resistance, just deciding to keep going anyway. Next slide, please. Now, here's why the training at home model matters, especially for this community. Think about everything it actually takes to access consistent support when you're living with a TBI. Transportation, scheduling around fatigue, managing sensory overload before, during, and after an appointment. The energy it costs just to get somewhere and come back. Those barriers are real, and they make it harder to do the one thing that actually matters most: show up consistently. Neurofeedback isn't a one-time thing. Like physical therapy, the benefits build with regular, repeated sessions. 1 or 2 sessions might feel good, but it's the consistent training, session after session, over weeks and months, that tends to produce lasting change. When someone has a system at home, those barriers disappear. No ride to arrange, no waiting room when you're already running on empty, no 2-hour block carved out of an already exhausting day. Just you, your couch, your headphones, and 33 minutes. And there's something else about home use that doesn't get said enough. It gives you ownership. You decide when to use it. You choose how to set up your space. You pick what you want to watch or listen to. That's your call. For someone who has lived through the experience of things happening to them, medical events, systems making decisions about them, being the person who decides to show up for themselves every day in their own space, on their own terms, that matters. The message it sends yourself is real. I am still doing something for my own brain. I am still in charge of something. Rolling Start gets this better than most. Their whole mission is to educate and empower people with disabilities to achieve the independent life of their choice. That's not just a tagline, it's how they operate. And that's exactly why this partnership has meant so much to me. Not because it's good for business, because it's the right fit. Here's what I want to leave you with. Your brain can adapt. That's not a pep talk, it's biology. Neuroplasticity is real. The brain's ability to reorganize, form new connections, and respond to experience doesn't have an expiration date. It doesn't stop at a certain age, and it doesn't stop because of a hard history. Every moment of calm you create, every tool you use, every time you show up for yourself, it's contributing to something, even when you can't feel it yet. Progress doesn't have to be dramatic to be real. Brittany didn't describe one single moment where everything changed. She described sleeping better, her thoughts shifting before anxiety could take hold, going back to her classes, having goals again. Those aren't small things. That's a life being rebuilt, one steady day at a time. Don't let anyone, including the voice in your own head, tell you that quiet progress doesn't count. And you deserve support that actually works in your real life, not some idealized version of your life where logistics don't exist in your actual life. With the fatigue, the scheduling challenges, the transportation, all of it. That's what accessible support looks like, and it matters more than most people realize. To every survivor who's here today, I see you. The version of you that showed up today, still asking how to move forward, that's strength. That is not a small thing. Your story isn't finished, and I genuinely believe there are chapters ahead of you that you haven't reached yet. To the Rolling Start staff and advocates, thank you for seeing the people you serve as whole people, not diagnoses, not case files, and for doing the daily work of making support real, not just theoretical. The work you do every day is the reason tools like this can actually reach the people who need them. Partnering with Rolling Start these past 2.5 years has made me better at what I do. Brittany's story and the stories of other consumers I've had the privilege of working with through this partnership remind me regularly of why I started this in the first place. Healing is personal, independence is possible, and the right support in the right form makes a real difference. Thank you.
Wow. Well, thank you. Thank you so much, Peter. I love hearing your story. That was my first time hearing your story, and it was an amazing story. I am so happy for this partnership. Before we go into question and answers, I'm going to pause for a 5 to 10 minute break. I think I forgot to take a break right when I got started. So I'm going to pause for a break. Everybody can go grab some water, go to the restroom, and we'll be right back. Hi, everybody. This is Jennifer Veal Raby, and I am excited. We are back from our break, and we have welcome back, welcome back. Hey, Peter, welcome back.
Hi,
Okay,
Jennifer.
Hi, Peter. He just did a phenomenal job. Oh my goodness! And guess what? This is not his first year. This is his second year, and so it was just dynamic to hear your story. Thank you so much. So now, guess what,
Mhm.
everybody? We're going to take some questions, some live question and answers. Peter, are you ready?
I'm ready.
Okay.
Hello, my name is Leslie. I'm wondering the difference between the neuro-optimal and traditional biofeedback.
Sure. So, neurofeedback is really a type of biofeedback for your brain. Biofeedback's generally used on things other than your brain, but the concept is similar. It's giving your body direct information about what it's doing so that the body can self-optimize. So with biofeedback, sometimes you'll wear a heart rate monitor and such with the goal to lower your heart rate overall. With the neurooptimal neurofeedback system, the sensors are listening to your brain activity, and then the pauses in the music are signaling to your brain when it's doing something. And over time, your brain generally tends to learn, get the gist of what the pauses are for, and it tends to start to optimize, and your nervous system tends to calm down from repeated sessions.
Oh, that was great.
Does the neuro-optimal sessions help with rewiring your neural pathways, promoting positive neuroplasticity?
So, um, somewhat, yeah. So it does work directly with your brain's ability of neuroplasticity. It's directly utilizing neuroplasticity. So yes, it will inspire more use of that neuroplasticity as your brain is adapting and learning new things. And when that happens, you're generally forming new neural connections, from what I understand. So yes, I believe so.
Awesome. Here is a question for our virtual audience. And it says, I like that neural optimal supports the brain to heal itself. Also, relieving that I can do it at home. What is the setup like, Peter? Is someone available to help me if I have any questions?
Yes. So the way it works is I send out the whole computer system to your house. It's just a tablet computer, a set of sensors, and a couple accessories. And what we do is once it arrives to you, we help you set it up over a video call because you're doing this at home. We'll do it over a video call. If someone in particular can't do it over a video call, we'll make alternate arrangements. But we 100% help you set it up and get comfortable with using it. And then throughout the rest of the process, we're really there as support as much or as little as you want. So it is a do-it-yourself program. We're trying to empower you to be able to do this on your own. But if you have any questions at all, if you run into any problems, if you want any encouragement, we're always here every day to support you during the process.
Wow, that is dynamic. Okay, here's another question from the virtual audience. And it says, can neural feedback be combined with other treatments for better results?
Yeah, so technically, I just want to clarify that the neurofeedback is a training, but it is a very safe training to do. It's FDA approved as a side effect free, and it doesn't tend to interact with any other any treatments that you're doing alternatively. So we find that it works actually wonderfully in conjunction with other treatments, and often the combination of the training with the treatments will render even better results from what I've seen. So absolutely, yes, you can combine them.
Thank you, Peter. And here's another question from the virtual audience. It says, what are potential risks and side effects, and can they be monitored?
So, as I mentioned, it is FDA categorized as side effect free. However, in reality, my experience and the experience of my clients is that occasionally, because the brain is taking in new information each session, it can manifest a bit of mental fatigue. At the most, if people are doing, you can do up to 2 sessions per day with the system, and that's quite an aggressive pace, but some people choose to go at it aggressively because they want to make the most out of the training. So when that happens, sometimes people get a little tired from doing back-to-back sessions, and that's about the extent of a side effect that I see. And when that happens, it is remedied very easily just by spacing out the sessions and waiting a little bit longer for your brain to integrate the information it's learning in the sessions, and just giving it that space basically immediately gets rid of that side effect.
Oh, that is really good. And here's another question from the virtual audience. It says, typically, how many sessions are recommended?
So everyone's a little bit different. I always say that the average person needs between 20 and 40 sessions to feel some significant momentum or improvement. That being said, like every brain is different. So I've had clients who have felt what they described as miraculous changes after 1 or 2 sessions. It's like a light switch flipped on. And I've had other clients that need to do 80 sessions to really get some improvement. I think it just depends on where your brain, what condition your brain is in, what you're dealing with. It also, extrinsic constraints can be an influence into how effective the sessions are. Say you're eating a really poor diet at the time, that can influence the progress that you make. Whether or not you're getting 8 hours of sleep every night can be an influence. The system can help you get better sleep, so that if you're not getting great sleep, I mean, don't fret, that can improve. But if you were, say, staying up late and waking up early intentionally and just kind of burning the candle at both ends, it can really affect how many sessions you need, and you might need to do a lot more sessions than someone else.
And here's another question from our virtual audience, and it says, are there any other conditions that neurofeedback can help?
So the neurofeedback systems that I provide they don't treat conditions. It's really a training to regulate your nervous system and calm things down so that you can feel better. However, I mentioned traditional neurofeedback in my talk, and traditional neurofeedback absolutely can be a targeted approach to treating a condition. And people with more serious mental ailments, I will point them in the direction of traditional neurofeedback for those types of things like generalized anxiety disorder, clinical depression, things that are quite serious. Those can be helped by traditional neurofeedback. So if that's something you're dealing with, I suggest you go talk to a neurofeedback practitioner that has a clinic, and they can help develop a treatment plan for you. They can see what condition you're dealing with and create a customized protocol to help you improve your condition.
Wow, Peter, this is such really good information. Oh my goodness. Okay, and guess what? We have another virtual questions. Man, this is such rich information. Okay, so the question is, are there any risk or side effects?
So the risks, I would say there are little to none. I guess you could run the risk of using your time for doing sessions and maybe your progress is slow, uh, and you don't get the results that you like. That might be a risk for you. That's not usually the case, but sometimes someone just doesn't make progress quickly for whatever reason. Side effects, like I mentioned, it's generally side effect free. However, sometimes people will feel slightly fatigued from doing sessions too frequently, in which case you just space them out and that effect goes away.
And guess what, Peter? That was our last question. Wow. Audience, you guys did an amazing job. But guess what, Peter? You did a phenomenal job. Let me give you, I can't shake your hands. I'm going to give you a high five, a 10.
Thank
Oh,
you,
man.
Jennifer.
You're welcome, Peter. Oh, it was a pleasure to meet you. Okay, guess what, everybody? Thank you again, Peter. We have a great story, and I'm going to introduce our TBI specialist. Oh, man. Up after me is Mr. Richard Starks, our TBI specialist. Thank you.
Good afternoon. My name is Richard. I am the traumatic brain injury specialist here at Rolling Start. And first of all, thank you to all our speakers, to all our staff who helped us out, and to all our viewers watching it live and coming up, watching it later on YouTube. So I'm going to be introducing Rebeca, our next speaker. Rebeca Valenzuela Ferrer is an assistive technology coordinator at Rolling Start, a survivor of domestic violence and an advocate for individuals living with disabilities. In 2023, her life was changed after surviving domestic violence that resulted in both a traumatic brain injury and becoming a paraplegic wheelchair user. Since then, she has been learning to navigate recovery, healing, and adapting to a new way of life with resilience and determination. Through her recoverative journey, Rebeca has become actively involved in the wheelchair community, participating in wheelchair sports and connecting with multiple community organizations throughout the region. Her experiences have inspired her to use her voice to encourage others facing life-changing circumstances and to help raise awareness about traumatic brain injury, disability, healing, and empowerment. Today, Rebeca continues to share her story with honesty, vulnerability, strength, while embracing new opportunities for growth and connection within the disability community. By speaking openly about her experiences, she hopes to encourage others navigating trauma, disability, and recovery to recognize that healing is not linear, that rebuilding life after hardship is possible. Through advocacy, community involvement, and lived experience, Rebeca aims to help others feel seen, supported, and empowered as they adapt to life after injury and rediscover their sense of identity and purpose.
Hello, I'm Rebeca Valenzuela. Sorry about that. So I survived a domestic violence relationship, and it ended up causing me to have a traumatic brain injury and end up having to live now using a wheelchair. I am very glad that I have gotten to work with Rolling Start because they have provided me with a lot of help. They've taught me more about my disability than I even was aware of and ways to cope with life through living with a TBI. It's been a really, I could say, difficult but really exciting journey to be able to understand myself again and reclaim everything that I know that lives within me and what I'm capable of. Sorry, I'm just very excited. Hearing Peter's story and having to hear somebody else's story that Peter expressed was very beautiful and eye opening because I got to try the neurofeedback machine. I actually do have it at home too. It was very beautiful. I tried it the first time, and my first experience with it was I was kind of nervous. I was video chatting with Peter, and getting to put all the equipment together, it felt really nice. I felt empowered because it was something that I got to experience on my own. It was challenging at first. It was really nerve-wracking, I guess, because I was putting a lot of my time into something that I didn't know would help or not. After using it, the first session, 33 minutes of it, I felt so much peace within myself. I didn't know that I could feel happiness without finding it in exterior points. It brought me a lot of peace, and it felt like my brain was coming back together and parts of my head was being activated, and I felt this warmth come upon me that I haven't felt in a very, very long time. A lot of the things that I deal with are migraines. I have double vision, so it is really difficult to be on a computer for a lot of hours, to drive, or just it fatigues me. I get tired and my eyes go from being perfectly straight to one goes this way and the other one is straight, and my dominant is my left eye. So I I look more towards this eye. So if anybody ever sees me put my head down or go like this, it's because I'm looking at you and I'm trying to focus. Some other things that I deal with are I have a lot of bad memory. I, in the beginning, blamed it on that I maybe wasn't trying hard enough to remember things, or that I just wasn't trying, I guess. But I have to remember that I'm dealing with a disability that I'm also learning. So it's something that I've coped with. So I write myself sticky notes. I have 2 notebooks. One's a calendar, one's just for tasks and stuff. I also have a lot of reminders on my phone. I have alarms, probably like 15. I got a job at Rolling Start, and I work for the assistive technology department. I'm the coordinator. It's a really, really fun job. I love it a lot. There is times where I have difficulties because I am too scared to ask for help, I guess. It's more like I have a lot of thoughts in my head that I come up with, and I outplay them very profusely, and then sometimes I would rather just figure it out on my own instead of asking for help. But I am very grateful to have the coworkers that I have, because they go out of their way to ask me, do I need extra help? Do I need things? Can they help me move certain things if it's too big and they notice? It's really cool in the fact that I now live with a disability. It makes this job a lot easier to understand, because I have to either one, use the stuff daily, or I have worked with other people or have hung out with a lot of other people that have disabilities. So it's easy for me to pick up what people are saying and give them the tools that they need to move forward. That also has helped me in many ways, because I've met a lot of people that have traumatic brain injuries, and we all have different, I guess, personalities or traits that we play out. And it's been really beautiful to be able to be on our Living Well class that we have every month, to, I guess, get to know different people and understand their disabilities or their TBI and how it affected them. And in a way, I mirror people sometimes. Like I reflect and I'm like, hey, that's something that I do, and that's like I pick up things that I didn't see that I do in other people, and then I kind of work on it, and then I enhance myself. And it's really beautiful to be able to work together and create an environment where we feel safe enough to ask questions, to feel any emotion, and we support each other so much. Um, that's it.
Thank you so much, Rebeca. So I think we'll be starting with some questions. What are your goals moving forward from now?
Well, I took the class for the grant and was able to get a computer through that. So I plan on using that to go to school. And my goal is to become an advocate for spinal cord injuries and domestic violence survivors. I just want everybody's voice to be heard. And I think going down that route and being able to work at Rolling Start has really given me that fire and passion to really help people.
Great. Can you explain how the neurofeedback has helped your TBI?
Yes, it has helped my TBI in many ways. So, like I said in the beginning, my memory was really bad, and I was being really hard on myself about it. And because I have been using the neurofeedback machine, it's not that hard for me to put pieces back together and be like, hey, I left this here. I now don't use sticky notes as much, but I do write it down. I write stuff down, but the neurofeedback machine has helped me with memory, has reduced my migraines, like the intensity of my migraines. It's helped me with sleeping a lot. I have really, really bad sleep, and the first time I used the machine, I got a full 8 hours of sleep. The second time I used it, I slept like a baby. I don't even remember falling asleep. It's it's a really, really great machine. Everybody I speak to, I always talk about it, and I want to teach or let people know that it's not something to be fearful of or not understand. And if you don't understand, there's people out there that are willing to explain it. You just have to ask questions.
Thank you so much. How has sports, specifically adaptive sports, helped you with your TBI?
It's helped with my eye coordination, keeping active and staying healthy. I think sports has a really big influence in I think how our brain works, because we have to be one, active, pay attention, learn how to do teamwork, and be a part of a community. And all of that takes a lot out of people. I used to get really fatigued playing sports in the beginning. I didn't understand why I was so tired. My body was so tired, and my brain just it wanted to keep going. But and then I had these moments where I felt like I was burnt out. I continued sports. I continued elevating the intensity of the sports that I played. So I went from playing tennis to football, then sled hockey, and now I did basketball for a season, and now I'm doing para fencing. And each one of those sports has played a really big part in how I interact, how I not get mad, how not to get mad at things, how not to react. I'm a very reactive person. And because of the TBI that I got, it has shaped my mood. It has created this other thing that I guess happens when I get upset, this other person that comes out. And sports has been a huge help to get that energy out of me, to where if I feel upset, I go play a sport or go do something, and then that triggers me not to expel that in a negative way. It teaches me to respond in a healthy, I guess, adaptive way, coping way.
That's great. Did you experience any physiological obstacles or PTSD after your injury?
Yes, I did. Because of the type of injury that it was, domestic violence, I do have a lot of PTSD, which it triggers in weird ways. Like, it could be from sound, it could be from smell or sight. And I think because, well, not I think, after the TBI, it enhanced it more. So I get triggered easily. I hear something or some certain words just make me go off, and I become very upset or disassociate very quickly. And I'm learning how to cope with that. I'm learning how to deal with that. I'm working with a therapist. Um, and I do think that the neurofeedback machine has helped cultivate a new framework inside my brain and my heart, to where I just feel very peaceful in love, and I just want to be able to provide love and not negative energy or negativity, because it puts me back into those same patterns and loops that I don't want to be in anymore.
Okay. And how has your condition changed or improved over the past couple years?
I can say it's improved over the last year. Um, I've been able to pick up more sports. I drive a lot more. I'm not I'm not afraid to ask questions or speak up for certain things or situations anymore. It's um it's helped, like, I've working with Rolling Start, working with you, working with the TBI group. It's helped me cope and create a new version of myself that I love and I love to be around. And I know that continuing the neurofeedback machine, continuing the TBI group, continuing doing everything that I'm doing will help me in the long run. Um, it's helped me in many ways right now. I have more clear thoughts. I'm more happy. I can say I have a genuine smile. I love to come to work every day, and going home and knowing that I now have a schedule, I now have something to do, and adding the neurofeedback into that day it's a big part of my day. It's a task that I'm willing to take. Gives me independence, and it gives me something to look forward to, and I feel just very grateful.
And if I could speak on a personal note, I've known you for a little while, and the advancements and the improvement in your life that has happened in the last couple of years is unbelievable. I remember the first time you came driving, it was, yeah. Okay. You said you have the neurofeedback device at home. How does that work? Does the device get sent to our homes?
Yes, so Peter is an amazing partner with Rolling Start. I really do have the biggest heart for him. Um, he provides you with all the equipment. He sends it to your home. He even gives you his phone number so you could text him, and then he texts you like, "Hey, I sent it to your house. It should be there in 2 to 3 days." It came to be in 2 days, and it's such a beautiful package. It's big, like a box this big, and it's not heavy at all. It's neurofeedback from California, and it goes right to your doorstep, and you open it up. It has all the equipment that you need. It has headphones. It has the transmitter box, and then the pieces that connect from your ears, your head, and then it connects to your computer. Um, it's really easy to set up. You're on the phone with Peter, so you have extra help on top of that. Um, After that, you just log in. You log into your account, and then Peter tells you where you can start your session, and then he sits with you for a little bit, and then you start it. You can do. Sorry, it's my alarm to go to the restroom. You can do it from. I do it from bed. like to relax. I like to sit back. I like to be in the most peaceful position I could be in, which is fully laid out like a starfish on my bed. It's super comfortable. Um, After that, I just sit there for 33 minutes and I try to think about positive thoughts. I also like to look at the screen. Like Peter said, it's a mirror. It's very cool to look at all the patterns and the shapes, and it's really, I think it's very beautiful to hear the progress that you're making when you hear the machine pause and then it continues to play the music. It's like it throws you off and you're like, whoa, my brain's working. It's really beautiful. It's a beautiful device to be able to access and even have to get to use. If you can't get your hands on it, hit up Richard and ask for it, because it is a great device.
Thank you so much. And I believe that was the last question. So once again, thank you so much for sharing your story. I'm sure you'll see the messages in the live chat, a lot of encouraging words, and thank you so much for sharing your story. So I
Thank you guys
believe
for
that'll
having
be
me.
it. Yeah, thank you. So I believe that'll be our last speaker for the day. So once again, like I said earlier, thank you so much for all our speakers, all our staff, all our support staff, and all the viewers who are watching us now and in the future.
Thank you all so much. As we conclude today's second annual TBI or Traumatic Brain Injury webinar, I'd just like to say thank you to Dr. Dawson, also to Peter, and as well, Rebeca. Thank you guys so much for your knowledge, your expertise, your personal insight on TBI, all of your contribution that made this webinar informative, meaningful, and impactful to each of us. We also just want to thank everyone that was here today too as well and participated in today's event. Just want to say thank you again. Your support helps us contribute to building our community, help us to make more resources, more information to those that are dealing with a traumatic brain injury. I want to ask you before you leave today, if you would please take a moment to take our survey. Your feedback is so helpful to us as we go further with other webinars, other events. We would just like for you to give us your feedback on it so we can better and have a more insightful and more better webinar in the next upcoming years, and also other community events. Want to say again to you guys to follow us on Facebook, follow us on all the social media links that we have, just for your own knowledge of being able to see the programs that we have here, other resources that we may have available. We're constantly putting them on social media so that you will know. Want to say again, thank you for participating. Thank you for being a part. Thank you for allowing Rolling Star to take the time to be with you this morning. Want to say thank you again and have a wonderful rest of your day.